Hello, I'm Jonathan Schwartz, coming to you from CVI 2022 here in Denver. I've got Chadi Alraies at Detroit Medical Center with me. We thought we would change it up a little bit. It's an innovative meeting. You're always the one doing the interviews, so we thought we'd give you a chance to answer some questions.
Absolutely, yeah. Innovative approach.
It's great to see you.
Thank God.
I think you're speaking at this meeting on physiology with bifurcation lesions. Tell
Yes.
me a little bit about your talk and sort of what's going on in the area.
So as you know, the physiology, utilization of physiology is not as acquired in the practice as it should be. Right now in the US, there's only 13% of the cases are done with physiology and with IVUS. Despite a lot of trials coming up suggesting and advocating for physiology and imaging and better outcome, still that curve wouldn't make that jump. My talk is focusing mainly on bifurcation, how to evaluate how reliable physiology is for bifurcation lesion, pre-intervention, also post-PCI, as there is some more trials now suggesting post-PCI FFR, if it is above or below a certain level, the patient should do better if it is above 0.94.
Sure.
So I'm going to highlight some cases and how to approach them in physiology and some challenges.
I imagine it's pretty difficult sometimes. Just thinking about stenting a bifurcation lesion in general kind of makes people a little anxious. Does it add another level when you're having to do all this measurements and stuff, or what's your approach to that?
Absolutely. So when you are doing bifurcation, you have either one layer or two layer stent, depends on your technique. Mini crush, DK crush, provisional. But recrossability of the physiology wire right now is really limited. And even with the best wire, sometimes you have hard time recrossing stents going to the side branch. So using a physiology wire that is not designed for recrossing is becoming difficult too. So operator will be discouraged to recross again to evaluate if they do a good job. Similarly applicable to the imaging. If you recross the wire, then the IVUS doesn't go. So you have to dilate, you have to move that struts, you have open the struts again, and you don't want to disrupt the main branch stent that you just deployed, and you have beautiful result. So the approach is, if you have a good result angiographically and your TIMI flow is good and there is no osteal lesion, meaning Medina 101, you don't need to worry about it, and that's fine. If you have double stent and you have double lumens and confirmed and the wire goes smoothly and the IVUS can go, I will highly encourage that, because that will show you exactly if you reestablish your carina and you have a good position at the takeoff of the side branch. Physiology and extra layer of safety, as well as extra layer of efficacy that you are giving the best result for this patient to close a case with above 0.94, 0.92 IFR.
Sounds like it takes a lot of kind of planning ahead of time to really know what you're doing with these lesions.
Yeah.
We have a lot of options available to us right now with ways to assess physiology as well as imaging in the arteries.
Yeah.
What's your usual approach to that?
My approach is to stick with one thing, something you're comfortable with, the wire, the system, the readings, how to acquire the data. So it depends if you have Philips, you have Boston, you have Opsens, whatever you have in your lab, stick with it and get used to that wire, because that's going to be your workhorse wire for physiology. Do your things, all your intervention on the physiology wire for the main branch. If you want to recross again with the same wire, it's fine. If you have to use a new wire, reshape it for recrossability, it's fine. The disadvantage there, you are re-adding cost. You are adding a cost for extra wire. But again, if you think you want to need it for optimization, go for it.
Of course. Being an innovations meeting, I have to ask, do you know of anything new coming down the pipeline for these types of things, or where do you see the field going?
So we have a lot of now new technology coming from different vendors. Is the co-registration and optimized PCI is where it can show you exactly if you give this patient a well-apposed stent, and also if you have any residual IFR virtually without doing a pullback, without normalization, and worry about any drift, which is the side effects. I would highly encourage the operator who have this technology in their lab to use it. It's going to require one extra 2 to 3 cc of contrast as a final image to be done, which is just one of the disadvantage. But again, it value a lot and save you from all the hurdles from normalization and flushing and zeroing of the wire.
It's always a bit of a balance trying to decide, do I do more? Am I taking up too much time on one case? So
exactly.
We almost have too many tools in the tool chest at this point.
I always tell the fellows, perfection is the enemy of good. If you're good and you're happy.
I think we all hear that at some point in our fellowship. It's true. So maybe last question. We have a lot of some of the newer things are non-invasive assessments of physiology. Thoughts on that and how it interplays when you get patients that come in with those done? Do you often redo them invasively and measure them? What's your approach there?
Very important question. We started with the basic positive stress test, anterolateral, inferior lateral wall, and you have a patient with angina, maximum medical therapy, you go in and you see a lesion, you say, you know what, I have an non-invasive image. And I ask some experts like Morton Kern, do I need to do FFR in these lesions or not? And his question, you have enough evidence of ischemia, go for it. Again, if you see a lesion that is really, your gut tells you this is not significant, I don't think it hurts to drop a pressure wire and remeasure again and even normalize, do a pullback. Maybe this is a diffuse disease. Wherever you stent, you're not going to give any advantage with this patient. So when you have a pullback, and you have a diffuse disease, maybe medical management is good. The other one, if you take it to the next level, which I don't have right now in our lab, is the CT FFR, which is something completely non-invasive, completely innovative. And it's like CT coronary angiogram, but it tells you exactly where are the lesions. So that helps down the line to stage a procedure and exactly treat it in the future. If you have it, use it. If you don't, I think old is gold.
Fortunately, I think there's a couple trials ongoing that are enrolling, so hopefully we'll get some data to help back up some of our decisions. So
Correct. Exactly.
Last thoughts on all of this? It's very exciting times right now for complicated PCI.
I would say my main message is please use the physiology and imaging, please, because as I said, the United States now rate is 13%, and we saw it in FAME3, where the trial showed only 11% of people use IVUS, which is, this is a very controlled environment, so imagine what the practice is doing. Ultimate trial, you cannot beat that for TLR, TVR, better result when you do it with IVUS. So IVUS all the time is reimbursable. If OCT is there, it's to give you even better evaluation for high resolution with the cost of contrast as well as no reimbursement at this time. But please utilize your physiology and imaging as appropriate.
We have the tools that can help you, for sure.
Exactly.
Chadi, it's always a pleasure. It's great to come to you from CVI 2022. We're happy to be back. More to come.